Welcome to the Quality Improvement Strategies for Surveying Infection Control webinar. Let me take a moment to introduce our panel for today's session. My name is Polly Weaver. I am a project director for HMS. In my role as State Operations Director, my team and I provide management consultation to state survey agencies by reviewing survey programs and making recommendations as directed by CMS or at the request of the state agency. I have over 30 years of experience at the management level in state government and served as the Florida State Survey Agency Director for 21 years. Joining me today is Kristen Paulson-Aguirre and Sharon Whitehead. Kristen Aguirre is a subject matter expert with HMS and has over 15 years experience in healthcare, working in both provider and regulatory sectors of the industry as a health educator and surveyor. She has designed and implemented targeted training programs for surveyors and has a broad background in quality improvement. Ms. Aguirre has a Bachelor of Science in Recreation Management with a focus on therapeutic recreation and gerontology and is a certified therapeutic recreation specialist. Sharon Whitehead is a health facility surveyor with HMS and has 27 years experience in healthcare. Most of her experience has involved quality assurance activities, including over 8 years at the Missouri Department of Health and Senior Services, where she progressed from a facility advisory nurse to health and senior services manager. Sharon has a Bachelor of Science in Nursing and is a registered nurse. As we are all keenly aware, infection control processes and oversight of facility infection control practices are in the spotlight. As we considered survey data, we at HMS recognize that infection control, particularly in nursing homes, is frequently cited. However, we also notice that these deficiencies are not typically cited at a level to indicate negative resident or patient outcomes. We initiated a process to review survey results in an effort to gather data from relevant surveys to determine if we could identify practices that could be impacting survey outcomes. My colleagues who are joining me for this presentation will explain the details of the study conducted by HMS and the outcome of the reviews. We will then move to a discussion of quality assurance and quality improvement strategies to assist state agencies with internal oversight of surveys and the survey products, including survey reports and complaint investigation results. At the conclusion of this presentation, participants will understand the purpose and hypothesis behind the data analysis project, the method of data collection and analysis of this project, results of the data analysis, opportunities for surveyor growth indicated by the data analysis results, oversight authority related to quality assurance or QA reviews, the process for conducting QA reviews, the use of available QA review tools, and documentation management. At this time, I'd like to turn the presentation over to Kristen Paulson-Aguirre. Kristen?
Thank you, Polly. Hi, everyone. This is Kristen. I'm happy to be here today to present the data analysis process and findings for long-term care surveys. First, I will address the infection control citations during routine long-term care surveys. This includes complaint and recertification surveys. Then, COVID-19 focused long-term care surveys will be addressed separately in the next section. First, a quick overview of the data analysis project. Between December 22nd of 2018 and December 22nd of 2019, surveyors nationwide issued 7,143 citations at F880, Infection Prevention and Control. HMS conducted a review of a sample of 70 of these citations. The reviews were conducted by a panel consisting of 2 long-term care subject matter experts, a health facility surveyor, and the quality assurance manager. The citations reviewed were chosen randomly. The HMS review panel used a standardized review tool to promote inter-rater reliability. This review did not include immediate jeopardy level citations, as HMS had previously conducted a review of all IJ F880 citations to determine a hypothesis as the basis for this review project. From the findings of the HMS review of immediate jeopardy level citations, we hypothesized that, first, surveyors are not consistently investigating the facility's infection prevention and control program and its related systems, but rather are finding random observations and citing them without probing further. This could lead to a lack of identification of systemic infection control concerns and deficiencies in related practices, such as facility assessment, staff competency, training, quality assurance, and performance improvement. And secondly, surveyors are generally failing to include adequate interviews, observations, and record reviews in their investigations to identify serious or potentially serious outcomes. Thus, HMS proposed a broader study of all F880 citations to determine whether the evidence presented was sufficient to support the decision of noncompliance, whether all aspects of the deficient practice and related systems were included in the investigation, and whether evidence presented supported the severity and scope determination. The goals of the dataset analysis were to determine trends in specific failures cited, analyze surveyors' focus when conducting the infection control investigation, and identify opportunities for improvement related to surveyors' understanding of the regulatory requirements or writing a defensible citation. The first category we looked at was whether the deficient practice statement, or DPS, clearly summarized the provider's failures and quantified a relevant extent. Specifically, we looked at whether the DPS included the specific action, error, or lack of action, the outcomes relative to the deficient practice, the extent of the deficient practice relative to the total number of cases, resident identifiers that match the examples in the findings, and sources of information that match the evidence in the findings. The second category we reviewed, and perhaps the most important, was whether the findings supported and clearly illustrated noncompliance. The specific criteria we used included whether the findings illustrated deficient practice, whether pertinent interviews were documented for everyone involved in the findings, whether pertinent record reviews were included appropriate to the identified noncompliance, whether observations were documented as appropriate, and whether additional information was needed to support the determination of noncompliance. The third category we reviewed was whether the citation identified the sources through which evidence was obtained. Specifically, if there were observations, whether the date, time, duration, who was observed, and location of the observation were documented. If there were interviews, whether the date and time of the interviews and the identification of who was interviewed were documented. And if there were record reviews, whether the types and dates of documents used were included. For the fourth category, we analyzed whether the evidence supported the surveyor's determination of both scope and severity. And finally, the final score was marked yes, only if all four criteria were met. During the analysis, we also determined the specific failures addressed in each tag in order to further analyze trends and areas of focus for surveyors. The categories used to determine the specific failures included glucometer or equipment disinfection, standard precautions or transmission-based precautions, in other words, use of personal protective equipment or PPE, pest control, water treatment, emergency preparedness, resident care, which includes observations of care such as wound treatments, catheter changes, tracheostomy care, or tube feeding, hand hygiene, infection surveillance program, laundry and housekeeping, environmental services, policies and procedures, and of course, an other category. It's important to note here that some citations included more than one failure, so the total amount of failures we reviewed was 116. From the data analysis, we found that the lowest scoring category was the one that we thought was most important. The findings supported and clearly illustrated noncompliance. Only 7 of the 70 citations reviewed met the criteria in this category. The next lowest scoring category was that the DPS clearly summarized the failures and included all pertinent information. Only 16 of the citations met that criteria. However, both criteria 3, which is the citation identified the sources of evidence, and criteria 4, the evidence supported the assigned scope and severity, were neck and neck, and over half of the citations met these criteria. Only 3 of the reviewed citations met all 4 criteria. This chart shows the specific failure categories and the frequency they were cited. You can see that hand hygiene, resident care, and PPE use were the top 3 failures. Our findings indicated a pervasive misunderstanding of investigative techniques related to infection control concerns and deficiency writing. The specific failure categories indicated surveyors are citing F880 based on observations of inadequate hand hygiene, poor infection control practices during resident care, and improper use of standard precautions or transmission-based precautions. Surveyors are citing F880 based on random observations of infection control breaches made throughout the survey. We lovingly refer to these types of observations as the low-hanging fruit, since these observations are easy to spot during a survey, but don't drive down to the root cause of the problem. These low-hanging fruit observations are often indicators of systemic failures related to the infection prevention and control program. Also, many of the citations reviewed failed to include an interview with the facility's infection preventionist, or IP. In many instances, an interview with the IP could have facilitated identification of a systemic failure or aided in the appropriate scope and severity determination. Additionally, most of the citations reviewed failed to include an interview with a staff member who was directly observed in the deficient practice. This interview, directly from the source, could have led the surveyor to identify systemic concerns, such as staff training or competency. The findings indicate a need for additional training for survey staff in investigation into facility systems, such as infection surveillance, competency testing, quality improvement strategies, staff education, and responsibilities of the administrator, rather than citing just the low-hanging fruit. Also, there's a need for scenario-based training to aid surveyors in probing further in their investigations to determine the true significance of these random observations. This concludes the routine long-term care survey portion of the data analysis project. Please hold any questions you may have until the end of the presentation. Now, I will present the data analysis process and findings for long-term care COVID-19 focus surveys. First, a quick overview of this project. Between March 4th and June 28th of 2020, 49 citations at F880 nationwide were issued during COVID-19 focus surveys. A review panel consisting of 1 long-term care subject matter expert and 1 health facility surveyor conducted reviews of 35 randomly chosen citations. HMS reviewers again use a standardized review tool to promote inter-rater reliability. The goals of the dataset analysis were to determine trends in specific failures cited, analyze surveyors' focus when conducting the focus surveys, and identify areas of training related to understanding of the regulatory requirements or writing a defensible citation. To perform the quality analysis, the reviewers answered the following questions. Number 1, is the scope and severity appropriate based on the documentation included in the 2567? And if the answer is no, what should the scope and severity have been? Number 2, did the evidence and the findings support the determination of noncompliance? And number 3, were independent but associated tags cited when indicated? The final score was marked yes only if all criteria were met. The specific failure categories included in the analysis were implementing transmission-based precautions, PPE use, visitor screening and restrictions, staff screening, COVID-19 surveillance, facility reporting of COVID-19 to residents and families, policies and procedures for emergency staffing, lack of social distancing among residents, housekeeping and laundry, improper resident cohorting, infection surveillance, and of course, an other category. Because of the multiple failures cited in some of the tags, a total of 49 specific failures were identified. From the data analysis, we found that the lowest scoring category was the appropriate determination of scope and severity. Only 69% of the citations reviewed were cited at the appropriate scope and severity. Of note, 2 citations should have been cited at a severity level 3 for actual harm, and 6 should have been cited at a severity level 4 for immediate jeopardy. Each of these citations were originally cited at a severity level 2 for only a potential for harm. Additionally, there were 3 citations that did not include sufficient evidence to support the surveyor's determination of deficient practice. However, the citations scored highly in both criteria 2, the evidence sufficiently supported the determination of noncompliance, and criteria 3, any independent but associated deficiencies were cited when indicated. And 63%, or 22 citations, met all 3 of the criteria. This is a much higher number than we saw in the routine long-term care survey review. This chart shows us the specific failure categories and the frequency they were cited. You can see that implementation of transmission-based precautions, hand hygiene, and use of PPE were the most frequently cited. Our findings indicated a pervasive misunderstanding of severity and scope determination, with 2 actual harm level and 6 immediate jeopardy levels determinations that were incorrectly cited at severity level 2. Specific failure categories indicated surveyors are citing F880 based on observations of improper donning and doffing of personal protective equipment, failure to initiate transmission-based precautions when indicated, and inadequate hand hygiene. These categories again indicate surveyors are citing F880 based on random observations of infection control breaches made throughout the survey. Again, the low-hanging fruit. Since these observations are often indicators of systemic failures related to the entire infection prevention and control program, it is important the survey investigate further to determine root causes of the identified concerns. This could be an interview with a staff person observed to determine the education that was provided, the reasoning behind their action, and their understanding of the correct protocol. Or it could be an interview with the IP to determine other systemic root causes. These findings again indicate a need for additional training for survey staff into investigation into facility systems and scenario-based training to aid surveyors in conducting thorough investigations and determining appropriate scope and severity. This concludes the review of the COVID-19 focused long-term care survey data analysis. Again, please hold your questions until the end of the presentation. Now, I'd like to pass on the presentation to Sharon Whitehead, who will present additional data analysis findings for non-long-term care. Thank you.
Hello, everyone, and thank you, Kristen. My name is Sharon Whitehead, and I am pleased to be here to speak with you about the non-infection control citation review part of this project. For non-long-term care for infection control citation reviews, HMS assembled an internal team of subject matter experts, all with extensive experience in quality assurance and in evaluating the regulatory compliance of non-long-term care facilities. Since non-long-term care comprises many different care settings, in an effort to promote consistency of the final result, we chose to focus on just one non-long-term care setting, and ESRD surveys won that prize. For the sample, we selected 46 infection control citations resulting from 38 randomly selected ESRD surveys conducted nationwide between February of 2013 and June of 2020. Now, I just want to clarify that 12 of these surveys issued more than one infection control citation. So that's how we arrived at a total of 46 citations. 34 of these citations were from surveys that were conducted in 2019 and 2020. 2 of the surveys had condition level citations, each of which had 4 standard level citations that represented the condition. As with the combined long-term care review project, reviewers for non-long-term care infection control citations also used the standardized QA review tool to promote consistency in the review process and the reliability of the results. In developing our hypotheses, the review team's prior experience with non-long-term care citation reviews led us to believe that we would find that surveyors are not consistently investigating the facility systems related to infection control, but rather they're finding random observations and citing them without probing further. And just as Kristen said, for long-term care, the surveyors are citing that low-hanging fruit, and they're not getting to the root cause of the deficient practice. Surveyors are generally failing to adequately investigate concerns related to infection control, and they do not identify the serious or potentially serious outcomes. Inadequate investigation of the facility's infection control practices, along with failures to follow the principles of documentation, often result in poorly written citations, which are subject to deletion during QA review. The main objectives for our non-long-term care infection control citation reviews were similar to those for the long-term care review project. Our 4 objectives of the non-long-term care QA review included to determine the most frequent infection control categories and regulatory tags cited, to determine any trends in the identification and documentation of deficient infection control practices, to analyze the surveyor's focus when conducting the infection control investigations, and to identify any opportunity for improvement related to infection control investigations and deficiency writing. As previously noted, the review team used a standardized QA tool for the non-long-term care citation reviews. This tool is very similar to the long-term care review tool, with just a few of the questions and categories revised so that they correspond with the regulatory requirements and the principles of documentation for non-long-term care. Criteria 1 evaluated whether the DPS clearly summarized the entity's failures and quantified the relevant extent of the deficient practice, which included looking at the specific action, error, or lack of action cited, the actual or potential outcomes resulting from deficient practice, the extent of the deficient practice relative to the total number of cases, the appropriate patient and/or staff identifiers were used throughout the citation, and the sources of information used in the findings match those documented in the DPS. Criteria 2 evaluated whether the findings of the citations included sufficient information to clearly show and support the determination of facility noncompliance by determining if the findings clearly illustrated the deficient practice, if pertinent interviews were obtained from everyone that was involved in the findings or documented in the findings, if pertinent record reviews were obtained and if they were thoroughly documented, if pertinent observations were obtained and if they were thoroughly documented, and if the findings included sufficient evidence to support a determination of noncompliance. Category 3 questions evaluated the sources of evidence to see if they were clearly identified and thoroughly documented in the citation. Specifically, if the citation included observations, the date, the time, and when appropriate, the duration of the observation, along with who the surveyor observed, and the location of those observations were documented. If interviews were included, the date and time of the interviews and the identification of who was interviewed was documented. And if record reviews were included, the types and dates of the records and documents used in the findings were documented. And then for criteria 4, this was the one area that diverged from the long-term care review tool, both in the terminology by replacing whether the evidence met the assigned scope and severity, and whether by replacing scope and severity with standard level or condition level practices. Lastly, as with the long-term care QA review tool, for the final disposition criteria, all responses to the above probes were analyzed to determine whether the citation contained sufficient evidence to be considered a thoroughly documented and defensible citation. After the reviews were completed, we tabulated the results and analyzed what we came up with. And the results were divided into 4 categories to determine if the deficient practice categories that were surveyor cited and how often those specific categories were cited, how often specific ESRD regulations or VTAGs were cited, whether the citations met review criteria 1 through 4 and the final disposition, and the nature of any significant documentation concerns. This chart shows the 11 infection control categories used for the analysis and how often the surveyor cited each of these categories. Now, as you can tell, they're fairly polarized because 3 of the 11 categories reach double-digit percentages. The highest was housekeeping and environmental services, with 35% of the 46 citations falling into this category, followed closely by hand hygiene, with 26% or 12 of the 46 citations involving failures to perform hand hygiene and or failures related to the inappropriate use of gloves. In third place, glucometer and equipment disinfection had 17% or 8 of the 46 citations, and that involved deficient practices related to the inappropriate cleaning and disinfection of glucometers and or other equipment which the staff had used in the treatment areas. The other categories with deficient practices included transmission-based precautions and or the use of appropriate personal protective equipment. They had 4 citations, or 9% of the total amount. Then we had patient care, which included intravascular catheter care, administering medications and such. There was only 3 citations involving patient care, which was 7% of the total. We had the other category, and that was specifically related to vaccinations and hepatitis B status documentation, with 2 citations, or 4% of the total. Then we had policies and procedures with 1 citation, or 2%. Now, of note, none of the 46 citations involved deficient practices related to pest control, water treatment, emergency preparedness, or with the facility's infection control surveillance program. All right, this chart is a breakdown of I'm sorry, let me back up. I'm very sorry. The next 3 slides provide detailed information on the quality and defensibility of the citations as documented in the CMS 2567. This multi-page table includes the same 4 criteria categories with their respective criterion in the final disposition and reflects the numbers and percentages of the citations that failed to meet the specified measures. We will follow these results a little closer on the following slides. That's just the other part of it. Okay, now this slide reflects the overall tally for each criteria category 1 through 4, and also the final disposition. Of the applicable citations, in category 1 related to deficient practice statement, 93% of the citations failed to effectively document the DPS. Category 2, which is related to the quality of the evidence presented in the findings, 89% of the citations failed to clearly illustrate that a deficient practice had occurred. In category 3, related to the documentation of the sources of the evidence, 50% or half the citations failed to appropriately document what sources were used to support the findings. Category 4, related to support and determination of a standard or condition level practice, indicated that 41% of the citations did not clearly support those determinations. And then we're going to get a little bit more deeper into the specific categories now. And related to category 1, the deficient practice statement, 26% of the citations did not adequately define the nature of the deficient practice cited. 67% did not include an outcome related to the deficient practice when indicated. 41% did not include the extent of the deficient practice. Of the 22 applicable citations, 36% of them, if they didn't identify the patient identifiers correctly, or they didn't have them match with the findings. 20% of the citations had errors in the types and sources of documentation, or sources documented when compared to those included in the findings. Specific to category 2, for whether the evidence supported determination of the entity's non-compliance, 30% of the citations failed to illustrate that a deficient practice even occurred. 82% and 80% respectively failed to document pertinent interviews and record reviews in the findings. 29% failed to document pertinent observations related to the deficient practice. And 89% of the citations required some form of additional information to be able to support a determination of noncompliance. Specific to category 3, which is related to the sources used as evidence in the deficient practice, 18% did not include the date and/or time of pertinent observations, or they didn't identify as appropriate individuals that was observed. 4% did not adequately document the date and/or time of pertinent interviews, or the identity, when appropriate, of the individuals interviewed. 24% did not include the types and/or dates of the documents, policies, and/or patient records reviewed. And specific to category 4, regarding supporting evidence for the standard or conditional level of regulations cited, 41% did not present evidence supporting either one of those was cited, or there wasn't a standard or a conditional level deficient practice. The final analysis of the 46 non-long-term care infection control citations reflected the following implications for practice and opportunities for improvement. Overarching finding was that there's a necessity of a strong internal QA process for evaluating surveyor efficacy in the investigation and citation of deficient infection control practices. There are opportunities for building upon and clarifying surveyor knowledge and application of infection control standards of practice, of knowledge of the regulatory requirements and of the survey protocols for effectively and consistently identifying an entity's noncompliance with infection control regulations. And there are additional opportunities available for surveyor education in the importance of understanding and always utilizing the principles of documentation in the preparation of defensible citations. And this concludes my portion of the presentation. It is now my pleasure to introduce the next speaker, Polly Weaver, who will be discussing surveyor quality and assurance. Thank you.
Thank you, Sharon. As we've seen by the data that has been presented this afternoon, there are certainly some opportunities to improve survey quality. Surveyors have a very tough job, and with the challenges we're currently facing, survey work is getting increasingly more complex. This complexity points to the urgency for state agencies to have in place well-developed quality assurance systems designed to review survey activity prior to finalizing the survey reports. Section 1864 of the Social Security Act establishes the framework within which a state survey agency carries out the Medicare certification process. The 1864 agreement, Code of Federal Regulations, and the State Operations Manual all contain regulatory authority for the State Performance Standard System, or SPSS, oversight by the Center for Medicare and Medicaid Services. Section 8000D of the State Operations Manual outlines components of the SPSS, including reviews of survey activities. QA is a systematic process designed to verify that a product is meeting established requirements. CMS establishes expectations for survey performance. The SA then establishes the specific process to monitor completion of the duties on behalf of CMS, whether completed directly by the state agency or by agreement by another entity such as a contractor. The state survey agency is always responsible for the product that leaves the state survey agency. Documentation on the form CMS 2567 remains the key element in the record to support a determination to certify compliance or non-compliance with applicable requirements and, if necessary, to defend the determination before the public during the appeals process or in court. The state agency should have a written policy that outlines the process that will be followed for review of survey activity. The policy should include QA reviewer responsibilities, components of the various QA reviews conducted by the state agency, actions that will be taken after the review is completed, and the process that would be followed when a survey report is revised, including the process for managing the document versioning or document management. A careful and thorough review of the survey report and its supporting documentation can yield very valuable information. This information would include skill deficits of surveyors, teams, and sometimes the entire survey staff, variances in interpretations of regulatory requirements, promoting consistency in survey findings, identification of confusion between old and new regulations and processes. Also included in that category would be identifying confusion when surveyors who may be cross-trained apply regulations from one provider to a survey of another provider. Reduce the possibility tags are returned by CMS, overturned, or even deleted. These reviews would identify deficient practices that should have been cited and concerns not thoroughly investigated, and they would facilitate development of a suitable work product. Survey reports are reviewed to ensure basic principles of documentation and any additional writing style guide directives that have been implemented by the state agency are addressed. Familiarity with the language of the regulatory tag cited, interpretive guidance, and the POD are important if this review is to be successful. Reviewers are given the task to review the statement of deficiency and survey records to ensure the survey process was followed and compliance determinations appropriate. As we said earlier, the review of information included in survey reports can be complex. The degree of complexity is driven by the scope of the survey activity and the volume of deficient practice included in the report. QA review tools can facilitate consistent, comprehensive reviews. These QA review tools can include various components of the State Operations Manual, such as Exhibit 7A, which we all know and love to be the Principles of Documentation, relevant chapters of the State Operations Manual that speak to general survey processes, and importantly, general survey and certification processes, provider-specific survey guidance that is included in the State Operations Manual, and of course, Appendix Q that is included in the State Operations Manual specific to management of concerns related to immediate jeopardy. Other tools that are important in this process would include, as we mentioned earlier, state agency writing guides or guidance that is provided to surveyors on consistent writing of deficiencies that are not necessarily included in the Principles of Documentation. Survey QA review plan and policy that would help direct how that review should occur, and tools developed to guide and document consistent QA reviews. As part of the QA review process, state agencies have developed various tools to assist with consistent QA reviews. HMS also developed QA review tools that are designed specifically for review of survey reports and complaint investigations. The survey report QA tools are composed of two documents: a survey report QA review template and an accompanying survey report QA review form. The survey report QA review template, which is shown here, outlines the QA review criteria for assessing the statement of deficiency as part of the survey report review. The criteria include the metrics used by CMS for state agency performance monitoring through the SPSS, as well as additional criteria that are designed to assist the state agency with thorough review of the statement of deficiency. This template also includes specific guidance to each of the review criteria to assist reviewers in consistent assessment of each of the criteria. Let's look at the survey report QA review template in more detail. So as I mentioned earlier, the survey report QA review template includes the various criteria that has been identified to assist a state agency in validating that the survey report has been written appropriately and represents that a thorough review of the applicable regulations and survey processes have been followed. These criteria, as I mentioned earlier, include those that are used by CMS for evaluating state agencies through the SPSS process, but we've also added additional criteria that would assist in additional oversight of the survey product. These criteria that we have in this version of the document that you have in front of you includes the fact that that there is an explicit statement on the 2567 that actually notes whether the entity is in compliance or is not in compliance. And then as you notice, then we have the guidance then that would assist the reviewer to evaluate a particular deficiency related to that criteria. Other criteria that are included is that there is sufficient evidence on the 2567 to support a citation. The appropriate regulation was cited based on the evidence. The deficient practice statement, or DPS, meets the required criteria. The citation is written in plain language. The citation identifies the sources through which the evidence was obtained. We have specific guidance for long-term care that would include whether the evidence meets or satisfies the requirements for the severity rating or the scope that has been assigned. And then for non-long-term care, relevant guidance or expectations for the structure of the deficiencies for non-long-term care, because as we know, condition level deficiencies, standard and element levels follow somewhat of a different pattern than certainly long-term care deficiencies with the scope and severity. The last criteria that we include on the survey report QA review process is the immediate jeopardy citation evaluation, and this goes to whether the POD and Appendix Q were followed, including the development, utilization, and release of the CMS IJ template. Now, the template that I've shown you is not used necessarily, or is not used to document the review. This is used as a desk reference, really, so that the reviewer has that record in front of them, or that guidance in front of them as to what they will be doing in the review, the components of that particular review process. So as mentioned earlier, the second tool developed for review of the statement of deficiency is the survey report QA review form. As previously indicated, this form is used in conjunction with the survey report QA review template and applicable guidance. The survey report QA review form serves as the means by which the QA review of a specific statement of deficiency is documented. The review form contains each of the review criteria included on the accompanying template that we described earlier, as well as an area to document the findings for the specific survey report under review. We initially had developed these forms to actually, that the survey report would be, the survey report QA review form would actually be one form. But we found that made the form almost unwieldy because it was so large by the time we included guidance and then a place for the reviewer to note the specifics of a particular review. Therefore, we split the review form into two documents, or the review forms into two documents, so that you would have the template that would describe the criteria and then would go into detail relative to guidance for evaluating that criteria, and then another form that that coincided with the criteria used, but that actually gave the reviewer room to document their findings on the review. So now let's take a moment to look in more detail at the survey report QA review form. So as I mentioned earlier, again, since this is the document that the reviewer would use to document the actual review of a survey report or a statement of deficiency, this particular form then would include a place to note the name of the facility, the event ID, the survey date, the identity of the reviewer, and the review date. And then after we've included some initial instructions for completion of the form, then you begin with the review criteria. We include the same criteria, of course, that were included in the template. But on this document, since again it is used to document that review, we have an area where the actual tag number can be notated on the form. We have room here for each of the criteria for 6 deficiencies. If there are more deficiencies on the report that are being reviewed, certainly another form can be completed, can be added, so that you can review every citation that is included in a particular report. Directly below the citation is an area to indicate whether or not that particular tag met the specific review criteria under consideration. And then, because surveyors and managers and people that love to do QA love to have notes, we also provided an area where additional notes can be documented. So while the reviewer might indicate that a particular tag did not meet, say, review criteria 1, they can put additional information, include additional information under the notes section. Again, all 10 criteria that we reviewed previously are included on this form. And then at the end of the form, there's an area for additional comments that the reviewer can include. We utilize this form typically as a Word document so that the boxes can expand, as particularly this is important for the notes section, so the boxes can expand if there's a need for additional notes, and therefore the reviewer is not limited into the number of characters that would be included on a particular review form. Reviewers are also given the task to review complaint investigations, including facility reported incident investigations, to ensure established processes were followed. Reviews verify that a thorough investigation was conducted and that the compliance determination is consistent with the investigation documentation. As with the survey report QA review tools, the complaint investigation tools are designed to assist state agencies with consistent reviews of complaint investigations. The complaint QA review template outlines the QA review criteria for assessing the complaint investigation. The criteria include review requirements established by CMS for SPSS, as well as additional criteria designed to assist the state agency with thorough QA review of the complaint intake, triage, and investigation processes. Also included on this template is guidance specific to each criteria, again, to assist reviewers with consistent, thorough reviews. So now let's look at the complaint QA review template. As with the statement of deficiency or the survey report QA review template, the complaint QA review template provides an area that lists each of the review criteria and then guidance specific to that review criteria. And we think that the guidance is important because that assists QA reviewers to be more consistent and being consistent from review to review. And in situations where you have more than one QA reviewer, it produces or enhances perhaps inter-rater reliability. Again, because each of the reviewers are following the same guidance in evaluating each criteria. The review criteria that we've used on the complaint QA review template indicates those criteria that are included in the SPSS with modifications to pick up additional criteria that will round out that thorough assessment, including whether their pre-survey activity was conducted and an investigative plan developed and documented. For long-term care investigation, attempts to reach the ombudsman are documented. The on-site survey is conducted within the same time frame of the allegations. Survey methods were applied appropriately. The sample selection is appropriate to the allegations and the provider type under investigation. Documentation reflects that appropriate observations, interviews, and record reviews were conducted and reflect the use of the appropriate CE pathways, certainly for nursing homes, and other investigative protocols for nursing homes and non-long-term care facilities are used as necessary and as appropriate. Another criteria is that there is sufficient evidence to support the decision to cite or to not cite deficiencies. With guidance specifically for nursing homes as well as non-long-term care facilities, again, because the structure of the deficiencies and the survey process are different. If a possible immediate jeopardy exists, we want to ensure that the relevant components of Appendix Q have been utilized so that the use of the Appendix J and the determination of immediate jeopardy followed the expectations that have been documented and are available in Appendix Q in the State Operations Manual. And that also then on criteria number 9, that follow-up was conducted with the complainant and that is documented in the record as appropriate. The complaint QA review form is used in conjunction with the complaint QA review template and applicable guidance similar to the process we described for the survey report QA. This review form documents the results of the specific complaint investigation review. The complaint QA review form includes the demographic information necessary to identify the specific complaint being reviewed and provides an area for the reviewer to document the specific allegations included in the complaint. Following the listing of allegations is each of the criteria reflected on the accompanying template, as well as an area to document the findings for the specific complaint being reviewed. I would like to now show you the complaint QA review form in more detail. So a similar format that you saw on the survey report QA review form, since this document is used to, again, document, to be redundant, the actual review process, we include the demographic information so that you can identify what review was actually conducted. So you would have the name of the facility, the complaint number, the event ID, the exit date, and we've added the complaint priority so that the reviewer can document whether the complaint priority was appropriate, if the reviewer agreed or disagreed with the priority that was assigned by the triage team, the identity of the reviewer, and the review date. And as we said earlier, after we've touched on a few reminder instructions here, then the reviewer can list the various allegations that were included in the complaint investigation under review. And similar to the other report, to the survey report documentation form, review form, if there are more allegations, these can be documented on another form or can be added at the end of the form in an area that is designated for additional comments. So the reviewer by no means is not listed. The reviewer is not limited to only 6 allegations. Then we begin on the documentation form with the review criteria. Some of the review criteria does not have applicability to a particular tag. The review criteria would be relevant to the overall investigation process itself. So there's no place to note the tag number. Rather, the reviewer simply indicates whether or not the review criteria was met for that complaint. So in other words, for the first criteria to determine whether pre-survey activity was conducted and an investigative plan developed and documented, the reviewer can simply mark yes or no. And then again, typically because we like to make notes, then the reviewer can add any additional notes that they would want to add for that criteria. Similarly, if regarding contact or attempts to contact the ombudsman, that criteria would be relevant to the general complaint, not to a specific tag, as well as whether or not the on-site survey was conducted within the time frame of the allegation. So that would either be yes or no, and perhaps could be not applicable. But the notes would still provide an opportunity for the reviewer to indicate any additional information that they would want to note for that particular review. And then the remainder of the form picks up the rest of the criteria. And these criteria are applicable to specific tags or can be applicable to specific tags. So we've indicated or listed an area where 6 tags can be noted in the form. And then below the particular tag number, the reviewer can indicate whether that criteria was met for that particular tag that's immediately above the response. Then again, they can also include notes that they would want to document relative to any of the particular tags that they've made note of or to the findings. Sometimes we find reviewers have difficulty with a simple yes or no, and a little extra explanation is helpful. And if these forms are used to help inform follow-up with surveyors, that feedback is very important. So if there is insight that the reviewers have identified, that is helpful to document so that relevant information can be shared with the surveyors. So then we've taken all of those criteria, then the remainder of the criteria, and listed them in the form, and then associated that with the opportunity to designate compliance of each of the deficiencies under review with the criteria that is being reviewed at that point in time. And as I said earlier, then there's an area for additional comments if the reviewer has additional information that they would want to share. And also, as I said earlier, these forms are typically utilized as a Word document so that the reviewer is not limited to a certain number of characters in documenting their findings. So what should the state agency do if the QA review indicates that revisions need to be made to the report? The state agency should make every attempt to contact the surveyor or team leader as appropriate to discuss the findings that are in question. Such discussion should include a determination if additional information exists in the surveyor notes to substantiate the compliance determination and provide information pertinent to revision of the deficiency or deficiencies that are in question. If contact with the surveyor or team leader is not possible to enable timely processing of the survey report, deficiency revisions may well need to be based on information provided with the survey report and supporting documentation. The results of the QA review should be used to determine steps that should be taken in response to the review, including reopening the survey, and identify staff who need additional training or in-service regarding particular survey processes. I believe we're ready for questions. Tara?
Holly, there are no questions at this time, so we'll just give a few moments for people who want to submit questions in the questions box.
Super.
Still no questions as of this moment, Polly.
Okay, all right. Well, we thank you very much for the opportunity to share this information with you. And you all know how to get in touch with Tara, and she knows how to track us down. And we've got our contact information here as well. So if additional information is needed, feel free to reach out to us.
Yes, thank you, Polly, Kristen, and Sharon. The presentation has been recorded, and the slides will be available for the state agencies to review. Again, thank you so much, everyone.
Thank you.
Thank you.
Thank you.